Good afternoon, everyone, and welcome to this afternoon's Advances in Autism Research and Care webinar. We're happy to have you today. We have a really great presentation for you, but before I turn things over to Alicia, I just want to let everyone know how they can ask questions during today's session. You can type questions into the questions bar, and I will ask them of the presenter at the end of the session, or if you'd like to unmute yourself and ask a question that way, you are more than welcome to. And now I will turn things over to Alicia Halliday to do our presentation this afternoon.
Hi, everyone. My name is Alicia Halliday. I'm the Chief Science Officer of the Autism Science Foundation. I'm so pleased and very honored to be presenting this information to you today. I will say that I am presenting other people's data. A couple of cases, it's data that I helped collect and analyze, but mostly this is other people's data, including probably some people that are in the Autism Treatment Network and are investigators or research coordinators. So I'm very honored to be kind of condensing everything and probably oversimplifying a little bit in the short time that we have. But at the end of the presentation, I am very happy to take questions, and I'm also very happy to share my email address with you if you want to ask me anything else. So this is the first slide, and these are actually three of my favorite females with autism. The one on the left next to the beach is my friend Jill's daughter. Her name is Sophie, and she's moderately to severely affected. She has kind of minimal language and some severe behaviors. The one on the very right is Dina Gassner. She's an adult. She is a very high-functioning individual who is getting her PhD, and she was diagnosed later in life. And the little girl in the middle is my daughter, Sarah. She was diagnosed at age 3. She has some challenges, but I, have high hopes for her in her future. So really, what are the differences between males and females? Well, there's one very big difference that you can't help but address at the very beginning, and that's that the ratio of males to females with an autism diagnosis hovers somewhere around 4 to 1. So there are clearly more males being diagnosed with autism than females. And there have been some studies that have kind of re-examine that in the light of different screening practices, in different ways to ascertain people with autism, looking at different types of symptoms. So, it still hovers around 4 to 1. Sometimes you'll see it as 3 to 1. Sometimes you'll see it as 5 to 1. And that variability is caused by whether or not you're going into the community and looking for girls with autism, or whether you're looking doing kind of like a passive way of counting girls and boys, whether you're looking at straight autism and autism diagnosis or those with autistic traits. But all of this is kind of centering on the fact that there is concern that there's a diagnostic bias, and that for whatever reason, and we'll talk about this, clinicians are unknowingly kind of biasing their diagnoses so that more males get diagnosed. Now, even if you address that, the ratio is still higher in males than females. So it's clearly something that we need to better understand. Not only are more males diagnosed than females, females tend to be diagnosed later in life. So it's about 6 months later. When you look at the average age of a boy being diagnosed with autism, it's a little under 3, it's a little over 4 in a girl. When you look at Asperger's, it's like 7 in a boy and 7.5 in a girl. And it doesn't seem to be based on severity of symptoms. So this kind of divergence in the age of diagnosis isn't based on how severe the symptoms are. And it even, you can do the same, you get the same age of diagnosis in kids that have, in boys and girls, with lower IQ and behavioral problems. And so IQ seems to play a huge part in autism diagnosis, at least in girls. Interestingly enough, though, girls or females are overrepresented in the low end of the IQ continuum. And this is not kind of, I'll explain this graph and then you'll get to understand it. This blue here represents groups of people who have an IQ lower than 70 or are considered intellectually disabled or on the border of being intellectually disabled. If you look at the prevalence of girls to boys with autism by state in the CDC study, so males and females, if you look even across states, girls have there are more girls who are in the intellectually disabled category across all states. Now, of course, if you look at New Jersey, the difference seems to be very, very stark. If you look at, say, South Carolina here, there doesn't seem to be as much of a difference, but there's still a difference. So girls, there are more girls represented with intellectual disabilities. So they're overrepresented on the low end of the IQ continuum, which means that the girls that are diagnosed have lower IQs. And this shows up, this effect also shows up in other studies, so it's not just the CDC study. So this is an IQ less than 70. About 24% of males in the Simon Simplex collection, so this is a clinically ascertained sample, about 24% have an IQ less than 70, and that's this darker red. However, about 37% of females in this SSC have an IQ less than 70. So there seem to be more girls across studies that are kind of in this lower IQ category. So the other question is there a diagnostic bias? And I like to make this very, very profound, very thoughtful comment by saying it's not impossible that there is a diagnostic bias, that some boys are more readily diagnosed than girls. If you think about it, first of all, the diagnostic tools like the ADOS and the ADIR and even the SRS, they were, because there were more boys being diagnosed with autism, some of these tools were actually developed in male cohorts. And so the idea that, you know, you can present a car to a child and a boy will be, that's part of like what's in the ADOS, right? Is like these toys that may be slightly more male, more biased, and actually some of the cues that boys, it may be more kind of attuned to the cues that boys give. Now, you know, that's still under kind of discussion. I'm not saying that that's true or not true, but it is true that diagnostic tools were developed in male cohorts. Whether there's a diagnostic bias, I don't know. Also, the tools were not designed to capture nuanced differences. So if you think about the questions that these instruments, especially the interviews, were designed to capture, you know, one of the most classic ones is, does your child like to pay attention to little parts on toys like the wheels on a car? When in fact, if the answer to no is that, if the answer to that is no, what about, are girls, you know, do girls play with the arms and legs of Barbies, or do they arrange their shells or their other, like their little, like my daughter with her stupid Shopkins. The Shopkins are the focus of the interest. So, you know, it may not be able to capture the nuanced differences in some of these standardized instruments. Another thing that we're finding in anxiety disorders, it may be true in autism, is the clinician interpretation of symptoms may be sex biased. So what we consider a normal behavior in a girl, we may not consider that to be a normal behavior in a boy, and therefore it's flagged as being abnormal in a boy but not a girl. So we don't know that. That's a theory, and I'm throwing that out there because that's under investigation in other disorders, but that may be something that's out there. And then also, I think where most of the discrepancies across the prevalence numbers are coming from is where the sample comes from. So whether or not you're going into a community-based setting and just kind of like taking whoever comes, like in the Adams study where they just review medical records or they review educational records and they pick up autism diagnoses from different records, or whether or not they come into a clinic. If you're coming into a clinic, you're probably more likely to show some behaviors of concern that your parents or your caretaker is taking you into to get a diagnosis. And then also the referral source, whether or not the referral source was from a parent or whether the referral source was from another physician. So these are all things that might play into this diagnostic bias. And when I talk about referral source, this is what I mean. So this is a clinic. This is the unusually empty University of Washington Autism Clinic, which is usually filled to the brim, but they took a picture when it was empty, I guess not to scare people. And then this is from the community. So whether or not you go out into a school, and just kind of ascertain different cases of autism in the community, or whether or not you're waiting for them to come into the clinic because of some overarching concern. And this does make a difference in prevalence numbers. So for example, in the United States, we use the Autism and Developmental Disabilities Monitoring Sites. And as many of you know, this is a set of 14 states, including, and then I think Atlanta is counted separately, but I can't remember. So anyway, they go into the schools, they look at educational records, they mark whether or not if there's an autism diagnosis in the educational file, or if there are so many symptoms of autism, but a diagnosis was never formally made, they count those just based on people's records. So they use these records to identify cases of autism. And in the United States, that ends up, we have a prevalence of 1 in 68, and that's boys and girls, so the combination. The other option is to go out into the community and screen all kids for autism. So that means if your child goes to a public school, they would get some sort of screening instrument. Everybody in the everybody who goes to school, or everybody that goes, to this is supposed to be done, earlier, but anyone that goes to a doctor gets screened for autism. And then you have a direct assessment. So you're directly assessing everyone, you're screening everyone. Then those that test positive under the screening, they then get the full evaluation. And so theoretically, this is kind of what's supposed to be happening in the United States when we have universal screening for autism. When you go into a pediatrician's office and you get the MCHAT, and your pediatrician is then supposed to identify you as screening positive on the MCHAT and then referring you. But as I think we all on this call know, that does not happen. However, in a small province in South Korea a few years ago, they were able to pull this off, and the prevalence was 1 in 38. So literally, how you go about counting the number of people with autism makes a difference in terms of how many people have autism. So I say this in terms of boys and girls because how autism has been identified has led to some inconsistencies. So depending on whether or not it's a clinic-based sample or whether it's a community-based sample, some studies are showing some studies are showing lower rates of behavioral problems in girls, but some show higher rates of behavioral problems in girls. And some researchers have theorized that if girls have lower rates of behavioral problems, they're probably going unnoticed. They're probably showing things like challenges with social skills in school. They're not really fitting in. They're having some friendship challenges, but unless they show these kind of behavioral outbursts or stimming or flapping, they're not really being identified by teachers. The toddler boys, and we'll talk about differences across time in a minute, there's been a lot of inconsistencies here too. Some studies have showed that toddler boys have higher social abilities. Then some studies say, no, girls have higher social abilities. These are boys and girls with autism. And then some studies show, no, there is no difference. We'll talk about this in a minute, but clearly girls who don't have autism have a different set of social skills than boys do. And then females may have lower rates of restrictive and repetitive behaviors on average, but they do show a higher subgroup of repetitive behaviors, which is called a higher insistence on sameness. And I want to shout out to Tom Frazier, who's in the bottom right-hand corner. He is the new CSO of Autism Speaks, which I know is very supportive of the Autism Treatment Network. And he kind of spearheaded a lot of these studies, he and Summer Bishop. So he is really someone who's shown a keen interest in this area. So as I just mentioned, we all know that boys and girls are just different, and probably the way that they're just different is going to impact how they're diagnosed and the symptoms that they show in a disorder like autism. So in girls, they tend to have, and this is on the average from typical developing literature from typically developing kids, so not from those with autism. They tend to have a higher emotional regulation and recognition. They pay more attention to social stimuli than boys. Their cooperative play develops earlier. They have better verbal ability and they show less repetitive play. They do have different types of interests. Boys and girls obviously do. Anyone who has ever seen a boy or a girl knows that this is the case. Their behaviors are held at different standards. Certain behaviors are acceptable for one sex and not the other. And not all these things happen at the same age. So some of these social pressures, at least in girls, that occur, the pressures to kind of fit in, to be kind of part of the group, to be more like your friends, that happens in late adolescence in girls, and almost sometimes doesn't really happen at all in boys. So these are some of many typical sex differences, and so these sorts of things can impact how behavioral symptoms in autism boys and girls are shown. So that gets to the issue of camouflaging. So camouflaging is this theory that girls can maybe hide symptoms of autism better than boys. So girls have autism, but because of their higher, some of the things that girls have, like attention to social stimuli, cooperative play, better verbal ability, they kind of tend to hide or camouflage their symptoms of autism better. So there really is no difference in true prevalence of autism. Girls are just hiding it better. And so when I say they're hiding it better, they may be hiding behavior that's socially unacceptable. So they realize that hand flapping isn't necessarily socially acceptable, and they get weird looks, and so they're able to kind of quelch it a little bit. And they're actually artificially performing behaviors that are more socially acceptable. So they pre-prepare jokes to give in social situations, and they force themselves to make eye contact. It's a lot of work. This is really a lot of work. And if you have autism and this is going on, then you're certainly in some way suffering. So you still do have autism. It's not being recognized. And so it really causes an issue for a lot of girls with autism. Now, the idea of whether or not these things are conscious, whether people are doing these consciously knowing that they're forcing themselves to make eye contact, or pre-preparing jokes because they know that they think that they're different in some way and they don't want to be different, versus whether or not they're kind of just imitating other girls because it's more of unconscious reflexive behavior. This is an ongoing discussion that I'm having with a number of females with autism. I don't know. I think it's a little bit of both, but this is, at the end of the day, this is a lot of work. It's very demanding and it causes a lot of stress. So if this is going on, if girls are able to camouflage their symptoms or hide them or disguise them in some way, then can you measure that scientifically? I mean, is this actually going on? And so actually, yeah, you can measure it. So scientists have defined this issue of camouflaging, and this is their formal definition, and I'll give you what I consider the definition. So it's the discrepancy between a person's external behavior presentation in social interpersonal contexts, so an objective measure, and then the comparison of that between their internal status, which is their self-regulated emotional recognition and their autistic traits. So this is a difference between what other people see them as being versus how they see themselves. So if someone says, oh, you show a lot of eye contact, does that person themselves feel like they have normal eye contact? Do they feel like that this is something that they're comfortable doing, or does it cause them a lot of emotional stress? And as you can see, this was a study done out of the UK, that females have a higher level of camouflaging scores. So they're in this kind of pink red bars, and this is the mean right here with the standard deviation in the box. So if you compare this line here to the boys, which is this line here, the girls are camouflaging. They're camouflaging significantly more. I don't know if this can account for the entire difference about why girls show a lower prevalence of autism than boys, and why they're diagnosed differently or later or at all. But I can tell you that this is the sort of study that shows that, yes, to a certain extent, girls are either consciously or unconsciously kind of hiding their symptoms or trying to be so like other people that they're able to control kind of all, all of the things that would be red flags for autism. So again, this may not account for the entire diagnostic bias, but it might account for some of it. So what about the brains of males and the brains of females? And so, of course, yes, again, there are differences between the male and the female brain. And you would totally expect to see differences in the male and female brain of typically developing individuals, as well as individuals who have a diagnosis of autism. And this is a study conducted by Christine Wu Nordahl at University of California, Davis. I believe they're an ATN site. So anyway, what she did is she looked at the fibers, or the different regions in this area called the corpus callosum, which is the areas that connect the two sides of the brain together. It's right here. It's represented by this kind of inverted U-shaped shape right here, and it's white because it's just all neurons that cross the left and the right hemisphere. So here, if you look at the typically developing female and the typically developing male here, there's a little bit of differences here in the typically developing. But then if you look at ASD males and females, there's a huge difference. And then also, all three of these groups tend to hover except for the ASD males. So in this particular orbitofrontal region, there's a huge difference in males, but not in females. However, you move a little bit further back to what's called the anterior frontal fiber region, and that's just, you can see, this is the orbitofrontal region. Then you move a little bit back to the anterior frontal fiber region, and you can see there's a huge difference in females. So the ASD females are way out here in this dotted red line, where the rest of the groups are up here. This is an ASD male and an ASD female, but down here there's this huge difference. And then if you move even further back to what's called the superior frontal fiber region, so this is a little bit further back, if you look at the differences between males and females, so if you look at the ASD male, which is the red, and the typically developing male, both solid lines, here's the difference here between ASD and typically developing males. But look at the difference between females, and this is the dotted line, typically developing females and autism females. So there's a much bigger difference. And that differences having to do with whether or not you have autism. So the behaviors are different, and guess what? So are the brains, the way the two sides of the brain connect to each other. And I have to say, this is not the only difference you see in male and female brains. It's one that it kind of jumps out in the literature, but this is an ever-evolving field, and even more and more differences are being identified in the male and female brains. Oops, here we go. Oh, so here's the thing. So one theory is whether or not females have a more quote-unquote male brain. So if you look at this difference, if you look here, I'm sorry. If you look here at the ASD female, here it looks quote-unquote more like, it looks kind of like here, more like a male, right? So here's the typically developing male, here's the typically developing female. Here's the ASD female. It looks more, I mean, the difference here is not as wide. So it's looking, this line here is closer to this line here. It's looking more like a male brain. That may be an simplistic way of thinking about it, and I'm not saying it's not overly simplistic, but is that something? Does the female brain look more like a male brain? Does the female autism brain look more like a male brain than a female brain? And that's one theory, and it's one theory that actually a group in the UK has really been forwarding. And this is an empathy score. So this is the autism quotient score, and this is how females, now this is the control females, this is how they normally score on the distribution. Most females score about 11, right? And most, I'm sorry, right. So most females score about 11. And then in males, most of them score around a 15 to a 20. So there's a slight shift to the right in empathy. So these are two normal shaped curves. If you look at the females, they kind of look more like the males than they do the females. They have more of they both have a U-shaped curve, more towards, they have a higher empathy score, which is actually lower empathy. But the males have this other completely different shape, and the females, the ASD females, look more like that than they do. It's shifted to the right more than those than those without, the males without autism. So it's possible that that it's more of a male brain. I think that's one interesting theory, but I'm not entirely convinced that's the whole story either. But it's received a lot of media attention, and so next time you hear, do females with autism have a more male brain, now you kind of know what that means. So again, when I talk about when the symptoms are different, earlier I said, well, toddlers, may not show differences. Yes, they do show differences. No, they don't show differences. So what I attempted to do in these next few slides is kind of go through the lifespan and tell you what researchers know about what goes on based on the period in their life. And what you're going to see is that there are huge gaps. There are incredible gaps about what we know differently between males and females with autism across the lifespan, which is not unexpected because it mirrors the fact that we don't see the gap. Hopefully sympathetic to the fact that we really need more research in this area. So in infants and toddlers, for the most part, even though there are some differences, across studies, they don't show, girls and boys with autism don't seem to show any overt differences. You can kind of see subtle signs if you look at, say, baby sibling studies where they put these infants in these very high kind of sensitivity apparatus to look at very, very subtle signs that trained clinicians would not even be able to detect unless there was instrumentation. So there's really doesn't seem to be any overt differences. So then when you get into children and adolescents, and this is like anywhere between the ages, we say between 5 and 11, and 11 is early adolescence, you do see that boys tend to show some more repetitive and restrictive behavior than girls. And again, this could be because of camouflaging, but we don't know. It might be because boys show more repetitive behaviors with autism than girls with autism do. Girls tend to show differences in speech processing, so they have actually better speech processing. But you see that with and without autism. So again, this is typical development kind of impacting what is seen in individuals with autism. And then girls also seem to show greater impairments in face processing. And this is again in children and adolescents. Then when you get to adults, again, we don't really have a lot of data on late adolescence to adults. In adults, there doesn't seem to be as much differences in speech processing. Females and males tend to be able to get jobs at the same rate, but females have much greater difficulties keeping those jobs. And this is something that's been documented by Julie Lowndes Taylor at Vanderbilt in Nashville. And unfortunately, not much else has been studied. And I really would love the Autism Treatment Network to look in their registry and look at their data, and maybe in that particular age range with those particular comorbidities, you may be able to see, to illustrate or at least identify other differences or a lack of difference in the ATN registry. So I encourage anyone who's an investigator to look at that question. And if you are, thank you. But I was part of a study with Summer Bishop and Renee Jameson and Maricela Huerta, where we asked over 100 clinicians in the field across the country, a few of them in the UK, whether or not they saw in their clinic any differences between core symptoms or associated symptoms. So we define core symptoms as anything that was on the DSM checklist, and then associated symptoms being medical comorbidities, seizures, GI problems, and also psychiatric comorbidities like anxiety and ADHD. And clinicians didn't really, just like what we see in the literature, clinicians didn't really see any differences early on in childhood. But once they got to school age, clinicians reported, even though they couldn't define it exactly, and they didn't say, oh, well, you know, I just see fewer girls with autism, so therefore this is my experience. They said, yes, of the girls we see with autism, we see they are different. They're different in core symptoms and then also by adolescence associated symptoms. So clinicians know that there's something different. They're looking for research to kind of back it up. Some of them are participating in this research, but clinicians, you know, and these are very well, I have to say, that they were very, they had seen a lot. I mean, some of them had seen, you know, a lot of girls every month. It was proportional, of course, to how many people they saw every month in their clinic. But these are clinicians that were, for the most part, very experienced, and they had been noticing that, yes, there are some differences. And there were some differences specifically in social symptoms, and I'm happy to share that paper with you. When we isolated, you know, what exactly the core symptoms were and what differences they saw, I can send you the paper if you want to see it. So the takeaways from the behavioral features, I would say, from the behavioral features of autism between boys and girls, there are more similarities than differences. Right now, what we know is, yeah, there are some differences, but boys with autism are very similar to girls with autism. The differences that we do see are kind of subtle. They're not things that if you had two kids, a boy with autism and a girl with autism, maybe you would be able to notice the differences in their autism behaviors, but maybe you wouldn't be. Maybe they show up a lot more similarly. They seem to be dependent on age. It seems to be the girls with autism show some more symptoms as they get older into adolescence and school age. And Connie Cassary at UCLA has been doing a lot of work based on friendships in girls and boys with autism and how typical girls develop friendships, and then how girls actually respond to different friendship overtures compared to boys. It may have to do with the social pressures. It may have to do with puberty. That is something scientists just don't know yet. But they do feel, clinicians do feel that there's something is different, and they also express less confidence in making a diagnosis in females compared to males. So whatever can be done, I think clinicians agree that it could be done a little bit better. So we talked about why, and we're going to move on to the next section. And if you have questions, please, I'm working to make sure that we have time at the end to answer everyone's questions. We've talked about some of the behavioral differences and how they may contribute to why there's a difference in prevalence. I've mentioned how male and female brains are inherently different, both in, there's just basic sex differences in boys versus girls. And I have to say that autism is not the first psychiatric or other health issue to have a sex bias. So there is actually a conference that every year is given. It's not a huge conference. It's not, it's not a big one, but it brings together researchers who study sex differences. And there are some pretty profound sex differences in a lot of different disorders. It used to be that ADHD was more diagnosed in males. I think that's changing a little bit, but there's still a sex bias there. Definitely anxiety. Females are a lot more likely to be diagnosed with anxiety than males. And then depression as well. So different types of depression, not bipolar, but certainly unipolar depression. So what can we learn from depression and anxiety? What are the differences? How can we learn from what they know about causes the differences in prevalence? And how can we apply it to autism? So because the male and female brains are inherently different, maybe there's something about a female brain that's protecting girls against some of the features of autism. So this is the theory called the female protective effect. And the idea is that if you have more genetic liability or more liability through environmental exposure or genetic exposure, and you have a lower prevalence of a disorder than compared to males, then you must be protected in some way. And here's what I'm kind of talking about. So if you have a liability for autism, and that can be exposures to risk factors like genes, environment, hormones. Hormones are an environment, but a lot of different things. If you have more of them, but yet here's maybe the cutoff for males that you see, that here's the cutoff for males. Any male with a cutoff of genetic and environmental factors above this level would get a diagnosis. Anyone below this level wouldn't get a diagnosis. In the case of autism, there seems to be more genetic liability. There seems to be more genes in girls with autism, but yet they're diagnosed less often. So here you have a higher liability, but yet a different diagnostic threshold. So there's a protective factor involved somewhere. Whatever is in between here is protecting girls in some way. So girls do tend to have more liability. They have more genetic liability. They may have more environmental liability. We don't know that yet. There are some intriguing studies, but they do tend to have a higher load of risk factors, but yet they don't have as high of a diagnostic level, and that's called the female protective effect. And you can see that here. If you look at this, this is the excess number of genetic factors in females across different types of genes. So the red is one type of genes, the green is another type of genes, the blue and the purple are other types of genes. And you can see girls have more of these more genetic factors. So they have a higher genetic load than boys do. So if they have a higher genetic load, why aren't they diagnosed as often? Another example of the protective effect is seen in the brains of girls with autism. And because there's not as many girls diagnosed with autism, there's way fewer girls or females to study in terms of looking at their brains. And so a study like this is incredibly rare and incredibly valuable. But what Cindy Schumann did at UC Davis is take different areas of the brain and look at whether or not genes were upregulated or downregulated. And the big circle means they were upregulated, and the little circle means they were downregulated. In males, so you have 38 upregulated and 16 downregulated in females. In males, you have 19 upregulated, which means they're turned on, and 14 downregulated. So if you add these two numbers together, you see more genes that are either turned off or turned on in females compared to those in males. So in the female brain, there's almost twice as many dysregulated genes. So what is it? Why are there fewer females affected with autism? And one of the ways that you can really help with this is to sign up for the Autism Tissue Program. I'm sorry, the Autism BrainNet. This is a program that encourages people to think about donating brain tissue for research. And I know that we've been in contact with all the ATN sites to at least explore the idea with people that come in for the clinic. I just wanted to let you know there's a reason why it takes brains to solve autism. One of the reasons is we need to know more about the female and male differences. So one of the things is siblings. So can you look at the female protective effect in siblings? So if girls with autism have a higher genetic load, wouldn't siblings of those girls also have more of a genetic load, right? Because they have more of a genetic load. Wouldn't the sisters or the siblings of the female probands, so the brothers and sisters of those females, wouldn't they show more genes, and then wouldn't they show more autism symptoms? And so this is what happened in 2 studies, one in the UK, and this is one study looking at data from the UK and from Scandinavia. These are siblings of people without autism, and they show a 0 autism symptom score. Siblings of boys with autism show a moderately high symptom score, but siblings of girls who apparently who may have a higher genetic risk certainly show higher symptoms of autism without having an autism diagnosis. And that was replicated another time in a different cohort. So siblings may be the ones that are holding the key to whether or not there's a higher risk of, they may be holding the key to find out why girls with autism are less likely to be diagnosed than boys. Are the girls with autism, or are the siblings of girls with autism, are they somehow protected in some way? I mean, they show a higher autism symptom score, but they don't have autism. And the Autism Science Foundation is funding a study right now called the Autism Sisters Project. It's a collaboration between ASF, Mount Sinai School of Medicine, UCSF, and the Broad Institute. Because girls are likely to have more genetic mutations, and this is Sarah, who's being very photogenic. If she has more genetic mutations than boys with autism, then what's going on with Jennifer, her sister, who doesn't have autism? Is there something going on with Jennifer that we can learn about why girls with autism have a lower risk of getting a diagnosis? So as a female in their family, sisters with the Autism BrainNet, or if you're at an ATN site, you make sure this material is just out. We're not asking you to talk about brain tissue to anybody in your clinic, but just make sure that the material is out. And then participate in research. So SPARC, Ian, and of course ATN. And again, I would love for ATN researchers to do an examination, or if you are doing an examination, let me know, of male-female differences. So I'm done. I know I talked very quickly and I apologize, but we can open it up to questions.
Great, thank you so much, Alicia. I just want to remind everyone that you can type questions into the questions bar, or you can unmute yourself to ask questions. We do have a few. So you touched on this a little bit when you were talking about the ATN registry, but what do you think are some important next studies that need to be done on populations of girls, or just on the subject of gender differences?
That's a great question. I think the ATN is pretty unique in that you're looking at a population, or at least a group of people that comes in through hospitals. And so what really hasn't been studied very well is whether or not boys and girls with autism, I mean, I know sometimes girls have higher rates of epilepsy, and there have been those studies, but are there gender differences in some of the other symptoms as well? Just GI problems in general, and if so, what type of GI problems? Neurological issues, feeding issues, that I think would be very, very interesting to know about, that might help guide how girls with autism are not only evaluated, but how they're treated. I also think that there's a very interesting link between feeding issues, eating disorders, and autism. And so I would love for more research to be focused on some of the comorbid symptoms that girls with autism kind of experience. So they do have a higher rate of eating disorders, but whether or not that has to do with feeding issues is still kind of elusive. I think that that's an important area to study. And also girls with autism, whether or not they're early on being misdiagnosed with ADHD, because of the difference in symptom presentation. So again, these are things that will inform not only how they're diagnosed or if they're misdiagnosed, but more importantly, how they get services and treatment and how their particular symptoms are handled.
Great. I think those are all really, really great topics and areas of research for anyone to kind of think through. And that kind of feeds into the next question that we have about whether or not you think we should rethink the diagnostic battery, and if so, how?
That's a great question. And so ASF and Autism Speaks, and actually Simon's co-organized a meeting in 2014. And it was really kind of not a think tank, but a meeting which ended up turning into kind of a think tank about what were the areas that needed the most attention. And some people in the room, I will have to say, thought, is it, posed the question, is it time to rethink the diagnosis of autism in girls? And so one of the first steps to that was that paper that I reported on, that we worked on with Summer and Renee and Maricela Huerta, where we looked at, all right, our clinicians actually knowing that there are differences, and how comfortable are they, how comfortable are they in terms of diagnosing girls? I am not going to advocate that the DSM undergo another overhaul, but I hope as the DSM progresses, or some of the criteria progress, instead of just giving male kind of, spinning the wheels on the car or taking apart, trains or things like that, that some more female kind of, not bias, but some more female related questions that may capture some more kind of female interest, if it's a repetitive and restrictive interest, and then also using questions or using ways to better kind of identify girls within the constructs and within the guidelines of the DSM. I'm not suggesting changing the DSM right now, but I think that there's probably room to make sure that girls are being accurately counted. Because, I mean, again, an autism diagnosis is, so that's assuming that, of course, there is a diagnostic bias. And I don't necessarily know. I mean, I think that you can say there may be, but we don't know that yet. I think that all of the studies that need to look at that, I mean, for example, in anxiety, what some researchers have been doing is going back to records and taking out the gender, or any gender specific, like he, she, the name, anything that would identify the gender of that person, and then handing it off to a different clinician and seeing what their interpretation of the diagnosis would be. That's something that's being done in anxiety. Should it be done in autism? I'm not necessarily sure it's the most important thing in the world at this moment, but I think it should be done, yeah.
Thank you. Those are some really interesting points. And those are all the questions that we have. I think they were two really great questions and provided some additional information. We can give folks another minute if they have questions, but otherwise, thank you very much, Alicia, for presenting today. And I hope that everyone has a great afternoon.
Thank you so much. And then you can also, I thought I put my email at the end of this, but you can just Google me and email me if you have any questions or ideas or suggestions. And ASF also has a fellowship program where we fund pre and postdoctoral fellowships, and gender differences is a priority area for us. So if you're an ATN researcher who has a fellow that is interested in looking at these issues, go to our website and look at our RFA. Hopefully this webinar may give you some ideas to use the ATN database. I hope it does.
Great, thank you so much. And I'm gonna sign off for everyone.
Okay, thank you guys.
Thank you so much.